Good evening. Thank you, sir, for the opportunity to present a case. Presenting the case of a 46-year-old male whose chief complaints were fever for 1 month and cough for 2 weeks.
Female, not male.
Uh, a 46-year-old female coming with fever and cough for this prolonged duration, especially in a country like India, we should rule out tuberculosis initially.
Thank you. Thank you. So that's your differential diagnosis.
So the other differentials at this point would be chronic infections like maybe any fungal infections, then any uh, like due to aspergillosis, then
Okay.
uh,
So
coming
give some differential diagnosis of chronic respiratory infection.
coming to the history of presenting illness, she had presented with complaints of fever for the past 1 month, which was high grade, associated with chills and rigor. So the chills and rigor states that it was rapid progression, and last fever spike was 1 week back, and with history of cough which was non-productive, and sweating and palpitation for 5 days, and 5 kg of weight loss over 1 week, and history of rhinitis before the onset of fever. So at this point my differentials would be that she had fever for 1 month with chills and rigor. So any fever with chills and rigor, we should suspect malaria also. But usually malaria doesn't present with 1 month of fever. And cough which was non-productive means that it more suggests towards a viral etiology or any irritative etiology in the lungs, which can be due to a lesion in the pleura, in the parenchyma, and history of sweating and palpitation for 5 days. The sweating and palpitation may be due to the defervescence of fever or any arrhythmias in the heart, which may be precipitated by the fever. And the 5 kg weight loss over 1 week means that there is a significant weight loss. And a history of rhinitis before the onset of fever can say that patient had a post-viral syndrome where the patient will expectorate sputum, but here there is dry cough, sir.
The oral disease commonly do not produce cough. Okay.
Yes.
Last
So
history.
coming to the past history, she had type 2 diabetes for 20 years, and as diabetic peripheral neuropathy was present. So her family history was significant for diabetes in her brother, father, and grandmother, and personal history was normal. So general physical examination showed patient to be conscious, oriented to time, place, and person. She was obese and with a BMI of 30.5. Vitals was only suggestive of heart rate of 120, tachycardia, and thyroid was bilaterally equally enlarged, moving with respiration, soft, smooth, and with no tenderness.
So at this time, do you have any other differential diagnosis?
So at this point, one important thing which I noted is that she had a strong family history. Always in a patient with a strong family history with 3 generations, we should suspect monogenic diabetes. If the patient is also having diabetes at a early age, at that point, yeah, we should test for C peptide, which would usually be normal, and then after that she had palpitation and tachycardia 120 heart rate, and thyroid is bilaterally and equally enlarged. So a fever with cough and with a thyroid swelling can indicate a post-viral thyroiditis, but usually it would be tender, and usually a equally enlarged uh, thyroid would usually be uh, can also be seen in Graves' disease, sir. And coming to the temperature charting, she had persistently elevated temperatures. The fever was so. My provisional diagnosis at this point would be uh, the fever and cough. So that would indicate first I would rule out TB. That would still be my first differential. But since there was a no thyroid swelling, which if the patient is having hyperthyroidism and the viral if there is a viral thyroiditis which initially causes a thyrotoxic state in a patient which can present as uh, usually doesn't present as a fever of 1 or 2 degree, but there would be a feeling of warmth in that patient, but cough cannot be explained due to the same for 2 weeks, which a cough
Your
may
diagnosis,
be.
your diagnosis is TB versus thyroiditis.
Yes sir. Yes sir. So, coming to the investigations,
Yes.
an ESR of 100 points more towards TB, and hemoglobin of 8.2, which is not, low, and a MCV of 87, normal MCV. Normal MCV anemia was there. Then SGOT and SGPT was normal. TSH was in the very low, 0.031, and T3 was 1.8, and T4 was 17.85, and anti-TPO antibody was negative.
T3 and T4 were high for the lab value.
Hello.
T3 and T4 were high for the normal lab value.
Oh, okay, sir.
So what is
T3
the
and
diagnosis now?
so a TSH which was low and a T3 T4 which was high can indicate that the patient is having primary hyperthyroidism. And
What are the causes of hyperthyroidism?
so hyperthyroidism can be caused ca- uh, can be due to mm, uh, can be due to any pituitary cause or a thyroid cause, and if the it can initially be due main most common cause is Graves disease, and where we will see diffusely enlarged thyroid ophthalmopathy as well as other features, and it can also be due to any post viral thyroiditis where there would be initially be thyrotoxic state in that patient, and it can also be jod based of effect due to excess iodine. Then any iatrogenic hyperthyroidism where the patient may be treated uh, for hypothyroidism where we supplement thyroxine, and then the patient may be then any multinodular goiter also producing the same, then
What other
papillary
investigations you are
the
planning in this case? What other investigation plan to differentiate between among the four you mentioned?
the other investigations which I would do is at this point would be, since the TSH was low and the T3 T4 was high, I wouldn't suspect a pituitary cause, and then I would do anti TPO was negative. So the other thing which can be done is a T thyroid receptor antibody, which can be done, which is quite expensive and not usually done in clinical practice. Uh, then other investigations which can be done is uh, ESR which was quite high. So you'll do a sputum AFP and CBNAT, then USG thyroid, ultrasound of the thyroid, and to look for any nodules, no any nodularity, even though clinically we feel that it is diffusely enlarged, we would look at whether there is a solitary nodule. And also we will do uh, thyroid cancer also, radio radio
Yes,
iodine.
sir. Graves'
Yeah.
disease, multinodular adenoma, thyroiditis, identity, thyroid pituitadenoma, it is very, very, very rare. So,
Yes, sir. This is the thyroid cancer, and
using what? Using what?
it shows decreased uptake.
Using what? Thyroid scan with what?
Uh, read technetium 99 or
Technician, technician. Technician done what opinion about this scan?
it shows decreased uptake, sir.
It's not take at all.
So
There is no
there
uptake.
is no
So,
uptake. So it is suggestive of thyroiditis, sir. Oh.
what's the final diagnosis in this case?
So my final diagnosis at this stage would be thyroiditis at a hyperthyroid state due to a infection, probably a viral infection.
So, what's the difference between thyroiditis, hyperthyroidism, and thyrotoxicosis? Are they interchangeable words?
Sorry.
Hello?
Am I audible, sir?
Yes, you're audible. Tell me. Is hyperthyroidism and thyrotoxicosis same?
No, sir. One is with clinical features. One is just a biochemical diagnosis.
No, 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 no. No, 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 no.
Okay.
Thyrotoxicosis is essentially a primary abnormality of thyroid which synthesizes alcohol. Hyperthyroidism can be due to different other causes, as
Ah,
you
yes, sir.
mentioned. So that is different. Okay. So how do you approach thyroiditis?
Uh, First, we should check whether it is painful or painless. Whether
So
there
what
were
are the causes of painless?
painless can be due to lymphocytic type, where silent lymphocytic predominant with and subacute lymphocytic in postpartum stage, which can then which which is associated with drugs like interferon alpha, lithium, then checkpoint inhibitors, tyrosine kinase inhibitors, chronic lymphocytic thyroiditis, as with Hashimoto. Then other drug which can be is due to is amiodarone. Then fibrous thyroiditis, iridials mainly. Then painful can be subacute granulomatous, viral subacute non-suppurative. Then due to infections, radiation, then like due to any injury to the thyroid cell. Then thyroiditis which presents as a hyperthyroidism will cause, that is 1 to 5 percentage of all toxicities is maybe due to thyroiditis.
What is
So
the
the
natural history of
the
thyroiditis?
natural history of painless thyroiditis is that it usually lasts for 6 weeks, and most of the time the patient will revert to euthyroid state, but if sometimes the patient may revert to hypothyroid state
How will you know that?
by serial follow-up, sir, of the and usually the thyroid follicles may get atrophied.
So what is the take-home message you have in this case?
So, in this case, I got to understand that for a patient who presents with fever, any kind of infection, and with either a painful or a painless neck swelling, we should check the thyroid status, and then if, after if the patient is having hyperthyroid state, then we should proceed with a re, uh, thyroid scan, and if it shows decreased uptake, then we can diagnose thyroiditis, sir. And we can tell the patient that the majority of the patients will come back to normal state, and only a minority will go back to hypothyroid state, and no need to continue medications, or no need to uh, uh, actually start medications for those patients, sir.
Clinically, how to diagnose toxicity?
Hello. Clinically,
Clinically,
to diagnose thyroiditis, usually there would be a preceding history of infection
no,
with
no, no, no. How do you diagnose toxicity?
toxicity. Okay, toxicity, usually the patient would be having increased tremors, then the weight loss despite good appetite, diarrhea, then there may be signs of thyroid ophthalmopathy in case of Graves. Then patients would be quite restless and would be speaking uh, with high speed. Then there would be brisk deep tendon reflex. Then there
These
may
are
be.
all these are all signs that you can get in a patient anxiety, behavior, talking the fast, not sign of toxicity. Two times of toxicity are tachycardia and tremor.
Yes, sir. Yes, sir.
So if you diagnose this as a thyrotoxicosis and then you start treatment with the drugs or surgery or radioactive ablation, results will be disastrous. So you have to pick up the diagnosis. So going
Yes.
back to the a patient with a toxic features like tachycardia and tremor with abnormal LF, TFT showing hyperthyroid status, how would you suspect thyroiditis? Painless patient.
Painless patient.
So important clues are very short history, history of fever, preceding, elevated ESR, leukocytosis, absence of eye signs.
Oh,
So
okay.
very short history, absence of eye signs, history of fever, raised ESR, raised count should give the clue to diagnosis. And all such cases you must undergo thyroid uptake study and then you get the proper diagnosis as in this case. And if
Yes.
you go back to the first slide, you see a fever preceded by respiratory infection followed by tachycardia, palpitation and weight loss with excessive sweating also.
Yes, sir.
So it is all pointing towards, so to read between lines, when the patient speaks, I'm sweating, I'm losing weight, I'm in palpitation, you must get a clue.
Yes, sir. Yes, sir.
Any questions?
I actually never expected a patient losing 5 kgs in a week due to hyperthyroidism.
Also note that she has got uncontrolled diabetes.
Yes, sir. Yes, sir.
And
So,
when
uh,
thyroid is inflamed, whatever thyroxine is there comes out of the body very fast.
yes, sir.
So obviously it will be symptoms and signs and weight loss.
Yes, sir. So, what would be the follow-up strategy for this patient, sir?
We have to follow up periodically with thyroid function tests, as you rightly said, and she may be going for hypothyroid state, but may recover to euthyroid also. Wait and see what happens.
Yes, sir. So, sir, can we suspect monogenic diabetes in this case, where she has a
Well,
diabetes?
well, actually, we did not concentrate on this patient. She has 20 years diabetes. Whether it's monogenic or polygenic does not make difference in the management. Am I right?
Yes, sir.
So
My yes,
for time being, our concentration is on only on the thyroid. Once it settles down, we will go to the other aspects.
yes, sir.
What's the clinical implication of monogenic?
Monogenic usually presents with a very strong history, especially a three generation history, and
What
usually presents young, and usually based on if the patient is having MODY type 1, especially he will have fasting blood sugar which is quite deranged, and the treatment is mainly sulfonylureas.
no, we told that this brother and sister is having. There is no three generation here. Brother, sister, father, no, and age of onset should be at below 35. All right. Okay, Anthony, you have done a wonderful job. Good discussion. Thank you.
regeneration, sir.